Hang on a second. Good afternoon. This is the Thurston County Board of Health, March 13th, 2018. I'm Commissioner Bud Blake, Chair of the Board this year. I'd like to start off by doing introductions. To my left is Commissioner Gary Edwards. To my right is the Clerk of the Board, Lydia Hodgkinson. To her right is the Health Officer, Dr. Wood, for Thurston and Lewis County. And to her right is the County Manager, Rivera Chavez. With that in mind, I'll call the meeting to order and ask if there's an approval for today's agenda.
I would so move.
It's been moved and seconded. It's been moved and seconded for approval of today's agenda. All those in favor say aye.
Aye.
Aye, and that motion carries. She's got an extra eye. We got 3 ayes. Join in. Okay. Is there approval for the meeting minutes for February 13th and acceptance of the work session summaries for January 31st, 2018 and February 13th, 2018 and February 28th, 2018?
So moved.
It's been moved second. It's been moved and seconded as stated. All those in favor say aye.
Aye.
Aye, and that motion carries. Well, today we have a lineup of presentations that I'm so excited about going on to cover. And one of them is what we call Code Blue. We have a very special guest to be able to talk about it. Code Blue is a subset of a plan we call Hazardous Weather Task Force, a task force that meets here on a monthly basis. And it's been a new direction as far as how we handle those who are out in the cold, and then also those other hazardous weather things. But primarily cold weather is what we're focusing on now. And it has, it's going to be explained, but I'll just kind of give you the gist. There's the seasonal portion of the plan, which is those things that where we have normal seasonal weather that we're used to, and we have about 250 something beds where people come in and out of the cold, and it's all about saving lives. And we have 5 or 6 agencies, sometimes 7, depending on what's going on as far as the flow of people. And those agencies handle on a normal, regular basis for what we know the weather to be. When the weather gets crazy and Mother Nature has what we call a snap, a hard freeze, snow, ice, or wind, and all those other combined things that go along, for a short period of time, I just use the hours of 96 hours or less, and we go into what we call Code Blue. And we do this surge where we ask other facilities to be able to open up their operations, open up their doors, and be able to handle that overflow from the seasonal portion of that. And then when we have the emergency, that's kind of county-wide, where we meet out at Tilly Road. We have all kind of roads that are closed from ice. It's multi-jurisdictional. It's probably North County, South County. It's a larger part of the emergency, and probably the whole region if you stop and think about it. That's kind of a 3-tiered layer portion there. But I've asked Meg Martin from the Interfaith Ministries to come and give us a briefing on the Code Blue portion, because it was just recently we had this particular function of the Hazardous Weather Task Force aspect, and it was just a great feeling to see the community come together, see the plan kind of work. We got a lot of work to do on it, but I think it's very relevant in terms of how we take care of people here in Thurston County. And I would just ask Meg to come to the microphone and give us a brief.
Good afternoon. Thank you for having me.
Yeah, Meg, how you doing?
My name is Meg Martin, and I'm the Homeless Services Director for Interfaith Works. We operate a year-round 42-bed low-barrier shelter in the basement of First Christian Church in downtown Olympia. And we serve highly vulnerable single adults, couples without dependent children, and their pets. And we also are a primary partner in the Community Care Center partnership with Providence, and operate a day center downtown as well on Franklin and State Avenue. But like Commissioner Blake said, I'm here to talk about the Code Blue portion of the response that we had for overflow shelter during a very cold week. Oh, I'll just back up real quick. That it was the Code Blue was called on 2/17, and it actually went through 2/24, but due to a lack of volunteer support and supplies, we had to call it after Friday, which ended up being okay because Saturday was a little bit warmer. So the only other thing that I'd like to say about this is that we were one response of the Code Blue at our facility. So First Christian Church, it's a 120-year-old building in downtown Olympia, and in the basement is where our year-round shelter is, and we opened up the upstairs for additional beds. But I do want to call out that the Salvation Army, the Family Support Center, and Community Youth Services, who all hold the county contract for providing overflow shelter during the seasonal winter months, did open additional space as well. So here are some of the numbers, and this includes the number of volunteers that we had in order to make this possible. And again, it was a drop of a dime Friday afternoon, as it always happens for emergencies, right?
Always a
and
scramble.
we called on all of our amazing team of people who've been there for us for a very long time. Some of those folks you'll hear from today. And we saw 85 folks sleeping in the overflow on our first night, and on top of our 43 folks in the nightly shelter for 128 people total. Sunday we had 115 total, 72 in overflow, 43 in the nightly shelter. We had 82 in overflow and 44 in the nightly shelter for 126 on Monday. We had 158 on Tuesday, 115 in the overflow and 43 downstairs. We had 103 in the overflow, 42 downstairs for a total of 145 on Wednesday. 83 overflow, 40 downstairs for a total of 129 on Thursday. And then we rounded out our week with 113 in overflow, 38 in the nightly shelter for 151. So that's a total bed night count of 952
Wow,
bed nights for that week.
that's a lot.
I would like to thank Commissioner Blake for coming and volunteering as an overnight volunteer. I think that it's extremely important for our elected officials to understand these issues right up front, and so I really want to thank you for that.
You bet.
So just quickly about the cost, we tend to do things on a pretty small budget, and so we saw a total cost for the week of $4,117.98, and that included my managerial oversight and volunteer coordination that I stepped into for that, support staff costs. So we did have, tried to have at least a minimum of 2 staff per shift, trained experienced staff members from the nightly shelter, but that wasn't always possible, and then we supplemented with volunteers. And then very modest supply costs. We were extremely bare bones, had not enough mats for people, not enough blankets for people. We were really lucky to have the community step in a huge way and provide snacks and coffee and kind of just comfort supplies as much as possible, but it was extremely bare bones. So some recommendations that we talked about at the Hazardous Weather Task Force, but I'd like to bring here as well, is in the future, when we know that this will happen again, that there's some type of coordination of what I've been calling the Code Blue supply kits, where there's bins of blankets or mats stored somewhere where it really could just be like a pack it in and pop it up shelter. And along with that would be a pop-up kind of how-to manual. We started putting one of those together for First Christian Church for next time in case, I'm not around or other people would need to step in to do that. We need to choose buildings that have or figure out a way to provide adequate sanitation facilities. So we did all of this with 3 toilets. So it really meant that there was a lot of lineup for people waiting, and that can cause a lot of issues. Also, again, the church is 120 years old, so plumbing is no small feat there. We need to consider a coordinated staffing pool idea that could respond at all overflow sites. So being able to find available trained staff in that short of notice was really a challenge. And so it'd be really cool to think about CYS, family support, and us all teaming together to provide staffing that could get shared among locations. Create and maintain a volunteer call list to supplement the staffing. So one of the great support that the county provided during that time was access to the Medical Reserve Corps email list, and we were able to receive, I think, about 5 to 6 volunteers on super short notice. And so getting together a list like that we could call upon in the event of a code blue. And with that as well, be able to coordinate those potential volunteers to attend existing trainings in the community. We do monthly trainings for all of our volunteers that are really comprehensive, and anyone is welcome to come to those, and so that could be a real resource to train volunteers. We also learned that organizing a hazardous weather transportation plan is going to be really key moving forward. Intercity Transit has offered to supply vans for that, but we just need qualified drivers. And so they're also willing to provide training for that, but again, folding that into some type of maintained volunteer list. And then to provide a clear funding pathway for organizations who do step up for this to get reimbursed for services that are provided. That would be a really useful thing in the future for our ability to do this again and again. And First Christian Church is one who has stepped up significantly in our community for decades to fill gaps whenever there is one. And so just wanting to see whatever we can do to support them in that. So that's all I have. I'm also available for questions if that's appropriate.
Yeah, you have a question or comment?
I don't know as I have a question as much as I do have a comment. Thank you to you personally for being the spokesman, but to all the other advocates that are out helping less fortunate citizens in our community. So thank you very much for all that all of you do to help these folks out. Thank you.
Yeah, I'd like to second that, but I know from firsthand experience, having volunteered that one night, but also when we do the point in time count and some other activities at the community care center, because I represent the housing action team for Thurston Thrives. That's why I love getting involved with this. But when we come together as a whole, no matter what walk of life you are, we put our hearts and our minds together and we have all the right resources. It's a beautiful thing just to bring people out of the weather for a short period of time. We're not trying to put them into housing or anything at that given moment. It's not the public permanent supportive housing or shelter or anything like that. Although there's beds and cots, it's not true sheltering in the sense of that. It's about saving lives, and I just think the world of you and those who were there that night to be able to say that you're the heroes of that time, and we are just super excited and delighted to have you continue doing this. So thank you so much.
Thank you very much for that. And one last thing that I would like to add is that whenever people go through downtown, it's very clear that there are folks that are sleeping in doorways, they're sleeping on sidewalks, they're sleeping under awnings around buildings. And the reason for that is because the math of the number of shelter beds that we have available and the number of people that need them do not match up at all.
Supply and demand, isn't it?
And what we were able to learn this week was if we were to open additional shelter space, would people use it? And I think, and what impact would that have on the actual number of people that are sleeping in doorways? And what we found was that particularly around the community care center building, the amount of people camping overnight dramatically decreased when we were able to open additional shelter options for people. So I think that that's a really important piece when we're looking about how emergency shelter options fit into the overall picture of what all of our goal is, which is to eliminate homelessness, and how that can look. So thanks again to all the volunteers and for having me today.
You bet. Thank you, Meg. Okay, so that brings us to the next item on our agenda, which is the opportunity for the public to address the board. And I have here the the sign-in sheet, and it's a first come, first serve, and I'll just go down that. And so when I ask you to come to the podium, just kind of give me generally where you're at in the county and your name, and then you have 3 minutes to speak. And if you get to the 3-minute part, there'll be this little sound that kind of cuts you off. It goes like, something like that. But if you're midway through your thought, I want you to finish your thought. It really is important to us to be able to bring that to closure. But at the same time, I'll start asking you to bring it to start wrapping it up a little bit. But so the first person I have on here is Selena Kilmore. Yeah. Hello, Selena.
Good afternoon.
You're my battle buddy, huh?
We are.
Yes, right. We were there that night.
I'm going to say this, and maybe it's totally inappropriate, but I love knowing that I can say, maybe only the one female around who can say, I spent the night with Bud Blake. Okay, so that's
working.
out there. Right?
You're right. We were there working.
Anyhow, there are many, many things I could do in my 3 minutes. And I'm going to take us into a new place. And I'm expecting that we simply can do an invocation.
Okay.
And it encompasses, I think, all that we are trying to articulate all the time about the folks who are in such a dire strait they cannot articulate their own needs. So I would offer this invocation. Let the power of our knowing lovingly uplift all who are present in this sacred space, this space of truth-filled, enlightened, conscious awareness. Let the power of our knowing uplift and empower our health board members, Bud Blake, Gary Edwards, and John Hutching, that they may effectively initiate the actions and activities necessary to the timely manifestation of synchronistic solutions on behalf of those in our community needing and seeking the benefits of 24/7 holistic cocooning, especially today, those who are physically disempowered. Thank you.
2 seconds. Cocooning, can you just explain what the cocooning is? Because we talked about that. Mm-hmm.
I've been at this game long enough where we went from people being homeless and needing housing, people being homeless and needing wraparound services, and what they need more than anything is a retrieval of their dignity as human beings. Mm-hmm. And so this past year, as I have meditated on it, I have come to the term sacred and safe cocooning. Mm-hmm. And every one of us, everywhere, needs to be sacredly and safely cocooned. Mm-hmm. Some of us are much higher up, by God's grace, on the Maslow old chain that we all knew.
To the scale.
And some of us are not. And so when I speak about cocooning, that's what I mean. And when I speak about the physically disempowered, I talk about all of those who are dealing with incredible, incredible conditions and are out on the streets and are in the woods. So that's what I mean. Thank you for asking.
We got one more question. Mm-hmm. 2 more, actually. So.
Well, I don't know, again, if it's as much a question or not, but I would say to citizens that question what dedicated folks like yourself are doing, on a cold night, ought to go just take a blanket and go outside and spend the night. It's tough, and you know there's more to this. I mean, you mentioned with Bud, but I can attest to his heart. This Bud's for you.
Thank you.
Don't walk away, because Meg gave an overview of the whole operation and some of the resources that were needed and some of the expectations and all. But give us a snapshot of what we saw that night in terms of just good human care, love, and people coming in and out going. It wasn't violence every minute, every hour. Just walk us through a little bit of what goes on there, because it's not the horrific thing. Yeah, there's every once in a while someone gets a little testy because we're all tired or whatever. There's more something like that. Go ahead.
I think what I'm always astounded with is the sense of community among the folks who are coming in, and particularly in the cold weather. And the most difficult thing is when a person comes in raw cold. And the mats are gone, and the blankets are gone, and you have to face this person who's very cold, and you can say, there's coffee.
Yeah, we had coffee.
And there was lots of coffee by donation and generosity, but that's all we could do, and cups of soup. And yet, the caring about each other in spite of the climate. And that I think, and I was there several nights, and it was continuous, even as the cold days and the cold nights continued. Respect and reverence for each other did not wear off.
No.
And appreciation for those of us who were there never wore off. Mm-hmm. And that's an amazing thing, given how little all these folks have. So that's what it was like. It was ongoing, just constant, and yet the little needs were being met as best they could by generous hearts, and those of us who had the little to give were receiving bigger generous hearts. So it's a very amazing thing that happens, and it gives me hope that solutions can be found.
That's exactly right. They sure can. Thank you so much, Selena. It's
you.
great to see you again. Mm-hmm. So next I have Reverend Mark Dowdy. Yes, sir. Come on up. Nah, you're just starting. Go ahead.
Well, thank you for allowing me to briefly speak about this huge need in our community and cities. I'm Mark Dowdy, retired after 23 years as pastor of the United Churches of Olympia, downtown, and on the ground floor 11 years ago in helping faith communities who would participate establish temporary camps for the homeless on their properties, known as Camp Quixote. Mm-hmm. 7 years ago, Quixote Village was established as a more permanent site for homeless housing and is thriving today. However, this endeavor, as you know, to provide housing is only a drop in the bucket compared to our community's needs. And you've seen some of that. You know a whole lot more about the needs as commissioners than I do. There are various humanitarian organizations who define a humanitarian crisis or disaster. It could be a single event or a series of events that are threatening our communities and impinge upon health and safety and well-being. The natural disasters that we find, human-made disasters, even this lack of affordable housing and human services could be seen as an emergency kind of disastrous thing, preventing this large group of people that you talked about and that Meg has talked about from accessing their own fundamental needs for food and clean water and safe shelter and health care, all right here in Thurston County. In our county, as has been said, gravely ill people have to sleep outside because they have nowhere else to go except when the weather is horrible. So the horrible emergency is such a good thing and covers, but like recently when First Christian opened its facility as an emergency overnight shelter, and I got the data from First Christian of up to 300, but I don't hear that today, somewhere between 100 and 200, very needy people for almost this week. One was a mentally ill double amputee who had no wheelchair or ill-fitting prosthesis. Another was a person whose frostbitten feet were bleeding through his socks and who could not walk because he had no shoes. And there were others with untreated mental illness, and we all know that that is a huge area. Unfortunately, in 1973, when the state of Washington had a vote to do away with our mental institutions, I probably was one who voted in favor of that, and that has proven to be a disaster for mental illness in our communities. And then the issue of substance abuse disorders. First Christian...
Keep going, sir.
For a few nights, at least for a few nights, was able to give them a place to sleep, hot coffee, as Selena has said, a few snacks, but not health care of any kind. And I've heard a number of people in my 23 years of working here in Olympia with other churches say that the churches and other faith communities can take care of these needs. Well, let me tell you, they can surely help if willing to do so. And I don't want to get critical of my brothers and sisters in other faith communities, but there are so many who will not step up. Look at the empty churches during the week, recreational facilities, etc., etc. They can surely help, but they don't have many of the resources, and the numbers who go to church are drastically declining. We know that. But they have willing hearts in their members and their participants. So I think this is a community deal. We all need to dig deep in our heads and our hearts and figure out what we can do as individuals and collectively to move further toward embracing and addressing the needs of all the people who are suffering in concrete, workable, and doable ways. And if I can be of any help, please contact me. I'm willing to talk to churches. I'm willing to help out however I can in retirement. And so thank you so much for your ears and for your heads and for your hearts.
Thank you for your kind words, sir. You bet. Thank you so much. Okay, so I'm going to have one more person. Tony, did you want to come up and say a word or two? Yeah, come on up.
Yes.
Yeah.
Only because I made some promises.
Yes, right. I'm going to hold you to it. Yeah.
My stepson. And,
Okay. That's right.
I did promise in our battle buddy moments. I did promise that I would bring Mr. Bud Blake some kimchi that my fiance made. So I had to keep that promise as well as to my son, who I told I'd be here today. But it wasn't easy getting here.
Oh.
But I want to thank everybody that spoke and everybody that volunteered, all the donations that were brought. Like Selena said at first, going from having coffee to other warm foods that we could serve throughout the week. I was there 5 out of the 6 nights during the emergency COVID shelter.
Word of mighty, yeah.
The night that the 4th night, I asked my son, and I said, should I go back tonight? I don't want to be too busy, take time away from you because I'm kind of a stay-at-home dad. And it was really cold and snowy outside, and he said, he's 9, and he said, will you help save some lives? And I said, probably, yeah. And he said, you should go. And he didn't stop. He didn't miss a beat.
Yeah.
And when we pulled over at an on-ramp when we were going to our niece's 1-year birthday party, he gave one of his 3 Laffy Taffies to a homeless guy because we had given everything out in my car. I run around giving out things out with a budding foundation that we're starting, and I ironically didn't have anything left. He gave his favorite flavor to the person. So when I'm having anxiety, because I actually do better in a scenario when I'm from 11 p.m. to 7 a.m. with a battle buddy like Bud Blake than in a situation like here. But I think that's indicative of why we need to do something. Absolutely. I have these notes here that I just don't even feel like I should really cover too much of because so much has been covered by everybody else that came before me.
Well, let me help you out.
Thank you.
You are one of the kindest, benevolent, open-armed, wonderful heart-minded people I've met in so many years of my years going around this world and doing stuff in countries. And I just want you to remember, if you can remember the story where Matt came about, he was looking for a soup and you were helping him with a soup and what he did when you came through that door. Can you walk us through that and how what he did to you?
Sorry, was that the de-escalate with ramen moment?
Yeah,
I think, that one.
Yeah, right.
That individual was kind of already, I believe it was that night, and I apologize, I'm still trying to...
Oh, it was the second night. Mm-hmm.
Yeah, everything kind of blends together.
Trying
to get things on paper has been difficult, but he had actually lost his wallet that night, and Selena talked about the community, because another member of that community in that shelter at night found him and got him his wallet.
See?
Which in a situation like that, one would not think that something like that would happen, but that's one of the reasons why I can be around folks like that, because I recognize the goodness in people, because I've been in pretty rough and tumble situations myself with my own past. But
Dire Straits, huh?
Yeah. So.
Oh, good. Thank you so much. It's so good to see you again. Yeah.
You as well.
And we'll be doing it again in the near future.
I'd be happy to stick around and answer any questions that you guys might have.
Okay, yeah. Thank you, Tony. Okay, I just, this completes my list, and just look at in the audience to see by show of hand if anybody would like to come to the podium to address the board. Seeing no one, we'll move on with the program, and we have next, what do we have here? Okay, so we have suicide prevention and awareness. Ms. Erin Rice, Director of Behavioral Health and Student Support for Capital Region ESD 113, and she has a panel of experts, subject matter experts. She's going to introduce and give us a little bit of overview of a very sad subject, but a very realistic thing that's going on in our community, not only here in Thurston County, but somewhat in Mason County, if I have it correct. And I'll just turn it over to Erin. She has a great program, and we'll just listen to her.
Good afternoon. Thank you for having us. I'm Erin Rice, Director of Behavioral Health and Student Support at Capital Region ESD 113. Our ESD serves 5 counties, Thurston and Mason County, Grays Harbor, Lewis, and Pacific County. We serve over 44 school districts and about 70,000 students. Our ESD is licensed to do both mental health and substance abuse treatment. And one of the things that we are constantly dealing with is suicide, and trying to find the right resources and provide prevention and intervention and education. And so when Bud and I met a month or two ago and talked about kind of this and how I'd like to bring in some educational components and do some stigma reduction, he said, you know, it'd be great to do a panel. So I was able to put together some amazing panelists today, and our first person is Jackie. She's our clinical supervisor of our substance abuse treatment program in Thurston and Mason County. So I'm going to let her talk just a little bit about some data in our local region.
Yay. Hello, Jackie. Hello. Come on up here and tell us a little bit about what a clinical supervisor does, and then tell us the background story for local and state data. What do you do?
My name is Jackie. I am the clinical supervisor for Thurston and Mason County True North Treatment and Services.
Oh, True North.
So I've done this work for 14 years with the ESD, and started off doing prevention and intervention, and now I'm the clinical supervisor. So one of the things that definitely over the last 10 years that I've seen working in this field is that our kids are getting really sick, and they're medicating the way that they know how, and our staff are weekly referring to hospitals and weekly getting doing crisis management and making sure that our kids are safe and doing what they need to do. And it's in line with the statistics that show that our kids that are served by the ESD regional are doing worse than state. And so our kids are struggling, and they're using drugs and alcohol at higher levels at earlier ages, and we're seeing more and more struggles around problem solving and those kinds of things. So I would say every week we're working with getting a youth in front of a mental health professional to evaluate their safety and make sure that they are safe to be at home and be at school and be in the community, working with the DMHPs at the hospitals, and working with police, and working with administrations and school counselors and those kinds of things, trying to wrap as many services as we can around these kids that are really struggling. So what we know is that between the ages of 15 and 35, suicide is the second leading cause of death. We're very aware of that. With most of our counselors that have worked in this field for more than a year or two have dealt with one of our kids committing suicide. Most of us have dealt with our youth that have had suicide attempts, a lot of them multiple times. We've been in situations where our staff are running kids to the hospital after a group because we can't get a hold of parents, and sitting with them to make sure that they're safe until we can hand them off to a professional and those kinds of things. So we know that this is an issue. Our state is ranked the 22nd for suicide.
Oh, wow.
And a lot of those are youth. And so I'm excited that I'm on a panel with lots of different services that are available and a lot of good things that are happening. But it is definitely becoming more and more aware that this is something that our kids are impacted with. I've been really blessed to be in a school-based system where kids have access to this. I worry about the kids that don't, the kids that aren't engaged in school, that aren't have these resources around them, and who they're reaching out to and who they're confiding in, and how these kids are getting in front of a professional in order to keep them safe. But so I am excited that I get to be part of this panel, and there's positive things and good things that are happening as well.
Do you have a question or comment, Brian? Not yet?
Thank you.
Thank you.
Don't walk away.
Oh.
So my question to you
Okay.
is, one of your concerns is access. Can you just elaborate on that, what goes on in terms of your thoughts or professional approaches to access and what that means to you and to the recipients of that?
Yeah. So our kids get in front of us, and of course we're chemical dependency counselors, so most of our kids are referred because they've been in trouble for chemical dependency. We do have more self-referrals and parent referrals coming in, but most of our kids are disciplined, whether they're legally required or school required to come in. So access of, do they know how to get in front of a counselor? First and foremost, is there roadblocks with insurance, saying, that this is going to be extremely high cost for families to get their kids in front of a counselor? Is all those different things play into, can we get them in front of somebody that can help them maneuver that system to get in front of a counselor? So access. We've definitely seen access to services improve, where we have chemical dependencies counselors in most of our schools, and now mental health starting to trickle in as well and get them into the schools so that the kid can literally walk into a door and say, I need to talk to a mental health counselor or a chemical dependency counselor, and that they have that access, that our kids are screened initially for suicide ideation, and then throughout their treatment episode, that's something that's followed up with them by their chemical dependency counselor, that we need you to get into mental health services, and helping them kind of walk through that, because it's a complicated system for adults.
Yeah.
And when you're 15 and 16 trying to navigate it, it's even more so.
Okay, great. Is there another panelist that you'd like to interview before we go? Mm-hmm.
So every 2 years, our state does the Healthy Youth Survey. And what we found in 2016 is 1 in 5 students, high school students, seriously contemplated suicide. It's pretty staggering. We know that in our state, 2 students a week commit suicide, and 17 are hospitalized every week. So it's staggering. Our next panelist is Kathy Baudouin, and she is a parent, and where did she go? There you are. I'm like, maybe she isn't here. And she has been gracious enough to come today and talk a little bit from a parent perspective.
You bet. A little Houdini parent, huh? So, Kathy, can you do me a small favor and raise the mic up a little bit so we can get you? There you go. All right.
Okay.
We're in business.
Okay. I got this too.
Uh-oh. We're prepared. We come battle ready also. So we're
Okay.
good.
I think I can make it, though.
Okay.
So my name is Kathy Baudouin, and I'm here today as a mother who almost lost a child to suicide. 3 years ago, my daughter tried to kill herself 3 times during her junior year in high school. And I'm hoping that by sharing a bit of our story with you, you'll more clearly see some of the struggles faced by families as they try to get support for their children. I want to preface my statement by telling you that I have a lot of supports to draw from in my life, including very good health insurance through my employer. And that is not as common for many families dealing with these problems. So please multiply my struggles exponentially when you think of most families that are going through these same issues. So when my daughter was 16, she was experiencing very high levels of social anxiety. We brought her to a psychiatrist and started her in counseling sessions. These didn't provide relief, so the psychiatrist recommended that we try medication. The medication came with a black box warning, meaning a heightened risk for suicide, but we were told that it was safe and commonly prescribed for adolescents. We had our daughter seeing a counselor on a weekly basis, and we knew what to watch for, and we knew to watch for the signs of depression, so we decided to give it a try. At first, it seemed like the medication was working, but by 3 months in, she was a different person, and she didn't like that person, so she began to work on taking herself out of this world. After her first attempt, we got her off the medication, doubled up on the mental health support, and kept a careful watch. We were inaccurately told that the medication would be out of her system in 7 to 10 days. It actually takes 6 months.
Oh, wow.
A month later, her second attempt resulted in a 3-week stay in the only psychiatric treatment center in the state with an open bed. This was a truly frightening place for adolescents, crossing over with an adult drug rehab center. She returned to school heavily medicated on new drugs with a plan from the treatment center to do things like read to herself if she got anxious. 2 weeks later, she had a rough day at school where she had a heated argument with a friend. When I went to pick her up, she was nowhere in sight and didn't respond to phone calls. I searched the school grounds and contacted her friends. No one knew where she was. By the time someone found her, she was barely conscious and lying in the middle of a road on a dark and stormy night. She was brought to the emergency room just in time to lose consciousness. We spent the night in the ICU with an attendant on suicide watch. By this time, I was well aware of the ridiculous level of mental health services for adolescents in Washington. I actually had someone at Mary Bridge Children's Hospital tell me that we were 49th in the nation, which is pretty sad.
Yeah, it is.
And through personal research, I knew that our best hope was to get my child into the psychiatric unit at Seattle Children's Hospital. I had the knowledge and the resources to do this, and I also had a job that gave me 3 months paid leave to oversee my daughter's care upon returning home and back to school. Most people are not that fortunate. At school, no one knew what to do. I was able to advocate for a 504 accommodation plan that required all of my daughter's teachers to be aware of her specific signs of anxiety and to follow a plan for getting her to a safe space where she could be guided to use her cognitive behavioral strategies that she had learned at the hospital. Most students with mental health issues don't have these types of plans, nor do they have teachers with the training so that they can spot the signs that might indicate a problem. We had to use our plan a few times over the next year, and had the teachers not been made aware of what to watch for and how to respond, I'm afraid that we might be in a different place today. Our plans, both at home and school, were driven by myself and based on advice from experts that I knew through my own work as a university professor. This kind of access to services is not the norm in the community where I live. Most families cannot provide health care benefits that I have had access to for my children, and that puts these families at greater risk for different outcomes than what we experienced. While I cannot possibly convey the intensity of the struggles we went through as a family to access the support our daughter needed, my hope is that you will understand that the overwhelming majority of families that face these issues do so with little to no access to the comprehensive supports that they need. The attention that you can give this topic is much needed and greatly appreciated. Thank you.
There goes that word again, access, huh?
Yes.
Yes, that's twice it showed up so far. Any comments, sir?
No, there but the grace of God go I might say, on a lot of these topics we're hearing about today. Yeah. I really mean that.
Yeah. And just so you know, my daughter is doing very well right now, and she approved me coming here. And I read my speech to her. So.
Super.
Thank you so much, Kathy. Mm-hmm.
Thank you, Kathy. Next, we have Jessica Shook, who is a DMHP and the clinical manager for the Olympic Health and Recovery Service that is ran by the Thurston Mason County BHO.
Hey, Jessica. I know Jessica. Come on up, Jessica. You're going to have to explain what a DMHP is.
All right. I've made that speech a couple times, I think, in my career. So a DMHP is a designated mental health professional. Those are the professionals in the state of Washington who have the authority and the ability to do an assessment and make a determination about involuntary mental health treatment. So hospitalizing someone against their will. We have that authority for both adults and for youth. Our goal on our new DMHP team, we have a new team that we started as of February 1. Our goal on this team is to provide outreach in the community as much as we possibly can, to intervene and provide crisis assessment and involuntary treatment, involuntary assessment, as far away from the emergency room as we can get. We feel that this is in line with trauma-informed practice, particularly for youth, because for one thing, it's pretty traumatic to go to an emergency room. The main emergency room in this county that provides the bulk of psychiatric treatment is at St. Peter's Hospital. They do amazing work. They are very, very busy all the time, and they have many people in the ER at any given time in varying levels of trauma. That's not necessarily a comfortable or safe place for an adolescent to be. Doing our crisis intervention and our assessment out in the community also allows for more attention for the youth's environmental stressors. We can focus on their story. We can focus on what's going on with them. Any family dynamics, dynamics with peers, friends at school, anyone else that they interact with. We can give that more attention than being in an emergency room environment where the focus is on the diagnosis, the behavior, medication, any other way of kind of pathologizing that kid who's sitting in front of us. It's also a lot easier to develop a less restrictive plan for treatment to try and avoid hospitalization as much as we can. It allows for us to work better with family, to work better with schools, and with other professionals or support networks in the youth's life. There are a number of options available for kids that are less restrictive than involuntary hospitalization. We can work with families around parent-initiated treatment, which is a procedure by which parents can admit their kids into a hospital. We can work with the family around voluntary hospitalization. Sometimes it is the kid themselves that knows that they need help and they want help and they're asking for it, and we can help facilitate that. We can also connect them with wraparound services from Catholic Community Services, who provide some sort of follow-up crisis for kids who qualify. And then we can also be the bridge to maybe help connect them with other resources at their school or in the community.
Any questions about DMHPs?
No. You got your hands full, I can see that. Dr. Wood.
Sure.
I just wanted to express my sincere appreciation for the work that you all do. I was the physician at the Evergreen State College for 12 years and called you many times. Thank you.
Thanks.
Yeah, and it's a new team, you said?
It is a new team.
How is
yes.
that going so far as the newness?
I think that we are settling in, and we are setting some ambitious goals for ourselves in terms of service in the community and trying to provide as many outreaches and as much face-to-face time as we can. So we're working on it.
And just Tad, a little bit of information on a day in the life of a DMHP in 30 seconds or less. What goes on with a DMHP?
Well, I can tell you what it looked like when I left the office to come do this assessment. I had 3 staff on the phone, and I had 1 heading out the door to go to St. Pete's, and I had 1 following up on a potential referral from the jail. So we're usually moving pretty quickly. It's unusual for me to have so many staff in the office. We've been working on getting staffed up, and it's nice to have so many people around because we have plenty of work for us.
So it's safe to say you stay busy?
Yes, we do.
Okay, good. Thank you so much, Jessica. It's good to see you again.
Thank you.
You bet. Thank you.
Thanks, Jessica. Next, we have Sarah Ellsworth, who is our Behavioral Health Clinical Manager for ESD 113, and she's going to talk a little bit about our multi-tiered system of support that we provide in our school-based mental health programs.
Sure. Okay. It's not homework, is it? Is it homework? There you go.
Thank you.
So again, my name is Sarah Ellsworth, and I'm the Behavioral Health Clinical Services Manager at ESD 113. This will be my 10th year at the ESD, and I just want to echo something that Jackie said, that this last year, I think if you ask anyone on our team, was the hardest year that we've had probably in our careers, and a big piece of that is we have watched a lot of kids die across our region in the last year, and it's heartbreaking. And I'm very hopeful hearing stories like Kathy's and hearing some of the things that are happening across our community, that maybe the tides are turning and people's experiences will start to be very different. What you have in front of you is our multi-tiered system of support model for providing mental health services in schools. One thing I do want to say in prefacing this conversation is Washington State has a very disparate system for delivering mental health services, meaning when we talk access, that's a word we've heard a lot today. What young people have access to varies greatly depending on the source of funding that they have for their services. One of the unique things I think in Washington State is publicly funded Medicaid youth often have more access to more robust services than those youth who are privately funded through insurance. And that is important when we talk about delivering these services in schools, because oftentimes what schools experience is their students aren't able to all access the same services. And as an ESD, that's something we certainly are committed to changing. We want all students in a building to have access to the same services. When you look at this triangle, I'm assuming the Board of Health is familiar. They've seen something like this. It actually comes from a public health model. And what the theory behind the triangle is that about 80% of the student population is going to respond to universal prevention supports and efforts. These are things like building empathy, teaching positive pro-social skills, helping them identify their own signs and signs of their friends who may be struggling, how to reach out for help, those types of things. About 80% of our students will respond to intervention at that level and be able to function pretty well socially and emotionally. Another 10 to 15% will need some small group, transient sort of support for dealing with their social and emotional or mental health issues. These are usually short-term, time-limited, very situationally focused, and can be provided by school staff as well as partners from the community who provide services in schools. The students that need the most support fall into Tier 3, and that's where our intensive services lie. Again, it's a challenge for schools because we have some really great intensive services with our wraparound and some other things that happen. But again, only a certain subset of students have access to those services, which means a lot of our kids get really, really sick, end up hospitalized, end up having to have some really drastic things happen before they get the support that they need. And so the other thing that's really important to us is schools no longer have the luxury of just delivering academics. It's no longer something that a math teacher can say is, oh, mental health isn't my concern, or I don't need to worry about suicide, because it really is a rampant concern in our communities. And so part of our role is not to deliver these services at all levels, but really coach schools on their literacy and their ability to respond to crises. We do put mental health staff in schools, but a great example that I'll give is our mental health clinician at a local high school who has 6 kids that she needs to see in a day for mental health therapeutic services who are in need of those, who are experiencing their own trauma, their own suicidal ideation. And another student who's yet to come to her attention wrote a suicide note that was discovered by the school. And the school, not quite knowing how to handle that, thinking we have a mental health expert here in our building, we must go get her. Knocks on the door, interrupts a young person in the middle of their therapeutic session and says, you need to leave. I need this person right now to deal with this crisis in front of me. What we were able to say afterwards is that's not really appropriate. That was very disruptive for this young person who was, dealing very appropriately with their trauma with their therapist in the middle of a session. She didn't get the closure that she needed. And this is something in the future that we can sort of help coach you to deal with. So when you do have a student who's suicidal and my mental health therapist is out sick or in session or in a training, you have the skills and ability to be able to respond to that crisis appropriately and connect the services as quickly as possible for that student to have an appropriate response. And so that is some of the things that we really are attempting to do is even the playing field in terms of access, allowing more students to access services regardless of funding. We're trying to coach schools to be able to respond, not only provide prevention services, but also appropriate responses when and if those services are needed, and then provide intensive supports for those most needy students in a school building.
Great.
Any questions? So this is sorry, did you? No?
No, I don't know if there's words to express what actually goes on and what you guys deal with every day with very limited resources.
And you know, this model is really helpful for me to reflect upon, because when you're in it, just like I'm sure the DMHPs feel, is that this is all the time, it's constant, it's everyone, it's nonstop, and it really is just 5 to 10% of our student population, 5 to 10% of our young people who are really experiencing these tense issues. It's nice to step back and remember that, but we really do need to think about how we are serving those people who need those services.
And this is your MTSS?
Yes, this is our MTSS model. And so again, it provides some supports of what, or some ideas of what the supports look like at each tiered level and who might deliver those, and the students that may benefit from services at each level.
Okay, great. Thank you so much, Sarah.
Our last panelist is not able to be here. He is actually tied up in court across the street. Oh, wow. And so, but his conversation with us, so thanks to Thurston Mason BHO, we have been able to pilot a project in Rochester School District where we have comprehensive mental health. And so what we're seeing there is early intervention is really helping with identifying students earlier and getting them the help that they need. So we're seeing those outcomes there. And so again, thanks to Thurston Mason BHO and to our commissioners for providing us the ability to do some of these comprehensive programs and pilot projects. As Sarah had said, it seems like we are feeling there is a lot of crisis happening continually, and so our team put together a couple of events. So the first event, and you may have these, but I'll maybe Sarah, can you drop these off up there for me? So tonight is the kickoff of the movie called The Ripple Effect. Kevin Hines attempted to take his life at 19 by jumping off the Golden Gate Bridge. He survived. Since then, he's been on a mission to use his story to help others stay alive and find recovery. So we're hosting his movie tonight at 7:30 at Regal Theaters. If you're interested in attending, I have tickets. The story is about hope and finding healing and recovery. So with that, then we are going to host an event on the 29th of March from 6 to 8 at Capital Region ESD. Featuring Kevin Hines himself, so he'll be there speaking. And this is more of a call to action for our area. So we're hoping to put together a team of people that can really brainstorm, how do we do better at this? How do we reduce stigma? How do we increase prevention and intervention? Because we don't feel we can treat our way out of this, and we can't just continue to wait until kids are really, really sick to get them assistance. And again, there's not funding for this, so I put a call and a request into Thurston Mason BHO and was able to find some support for this as well. And so again, it's just really our partners that are helping us kind of take charge of this and bring in some events to help reduce stigma and bring this topic to you guys today. So with that, our panel is finished, and I appreciate your time today.
You bet. And if they want tickets for tonight, how do they?
I will have tickets right over here.
Okay, sure.
Or at the door.
At the door. There you
Yes.
go. Okay, sure.
Thank you.
Thank you so much, Erin. Thank you. So we're going to move on to the next department item. We have Sue Pointer. She's going to talk about the emergency preparedness and response here for Thurston County. And I think you're going to focus on the Medical Reserve Corps a little bit, are you?
I am, and a few other little topics. And I do have a PowerPoint somewhere, Lydia. Do we have that queued up?
We got to get the technology going.
Well, my name is Sue Pointer, and I'm from Thurston County Public Health. I'm an Emergency Preparedness Response Program Manager. And I'm here, I'm going to give you an update on three items that three projects that we're working on. And they all do tie together with our Medical Reserve Corps. We'll see if we can get the slide here before I fill some space in. That was an amazing, the presenters prior to that was absolutely amazing.
Mm-hmm.
So I do want to mention that I believe Liz mentioned that our Thurston County MRC, while we did not activate them, we put a call out, and so 5 or 6 of them on their own went down and volunteered a couple of those nights. And they've put a call out to us as staff to say we'd like to be more proactive. Yes, thank you. We'd like to be a little more proactive. So we're looking at, and I'll talk about at the end, some ways that we can do some pre-training. And what we've kind of looked at is forming wellness, MRC wellness teams where they would come down and help folks if they needed access to health care, if they needed, to get a hold of BHO, et cetera. So we're taking a look at that.
But it was Meg, though, right? Meg.
That's an additional thing we're going to do. So we're going to put
sure.
you all to work when you come to our volunteer appreciation night. So what I'm going to talk about today is our three current projects. We have many projects. A lot of our projects that we're doing, MRC is very visible, but Dr. Wood and Shelley could attest that there's a lot of things that go on behind the scenes. So I'm going to share a little bit of, and it's really about keeping residents safe, and everything we do is about people first. We oftentimes in emergency preparedness have to deal with stuff that isn't so fun, and in public health as well, but we always have to put people first. So the first thing I'm going to talk a little bit about is Emergency Support Function 8, and you may know that coming from emergency management in the Comprehensive Emergency Management Plan. Well, that particular chapter and the purpose of that, we are the lead. Thurston County Public Health is the lead on that. And really the whole role is that in that ESF8, and excuse me, I'm battling the cold that never goes away this winter, is really to mobilize and kind of coordinate for resource requesting our health, medical, and mortuary services during a disaster or an emergency. We have been working the last year on rewriting that plan with the help of some key partners, and I do have to do a shout out for one of my staff, Erica Catt, who is our perfect plan writer. She's been with us, again, a whopping 6-7 months, but we finally have a good team together. So really the whole point of the outcome and the purpose of that is so that we're better coordinated as health and medical systems to coordinate in the event of a disaster. I want to say a couple of things about the primary roles. We had some key partners that include the coroner, both of our hospitals, the BHO is critical, Mark Friedman was critical, emergency management, and critical health care. I'm going to take a moment. What we're doing right now is we're having critical health care, and what do I mean by that? Hospitals, long-term care, skilled nursing, dialysis, blood. In the event of a disaster, those categories are pretty important. Where people are going to go, if we have to evacuate people, if people have to surge. One of the things that my staff is doing is they're convening meetings with our critical health care partners in Thurston County because like any emergency, it's building relationships first. If you don't have that relationship. One of the biggest groups is our long-term care who are so thankful that we're pulling them all together about every quarter to talk about their needs. They have some additional preparedness needs because of the new requirements for Medicare and Medicaid that they're required to do, and that's new to them. So we're pulling them in together with that. I'm going to talk about an activation. We actually have recently activated ESF8. So the new ESF8 plan, I think, was minted and signed off by the state on the 17th of December. And the train derailment, Amtrak train derailment, happened the 18th.
Oh, my God.
So just briefly on what our role in public health would be with ESF8, we stood it up. What our job is really is to act as a liaison and to gather situational awareness for all those key components of our hospitals, support for one of our hospitals happens to be the Disaster Medical Coordinating Center. So what we ended up doing, because it involved 2 counties, it was very interesting. We were working with a group from Seattle that was doing patient tracking. We became the liaison, Thurston County Public Health ESF8, for our 2 hospitals because those 2 hospitals received patients. So we were able to get that liaison piece picked up. They use a system called WATRAC. We were able to help support that. And why we are not on the grounds as a first responder, and I do have to say, Thurston County's efforts were above and beyond in that incident. And, but we provide some of the back pieces of that coordination if there were things that were needed. So that's a good example of how we recently activated for ESF 8. And what we create is a situation report, and we share that with all of our key partners, because one of the biggest challenges in any kind of emergency response is communication, is not having a clear picture. And we found that on numerous times. The second project that I'm going to talk to you a little bit about is medical countermeasures. So that's another, I should say, chapter in our emergency operations plan. Every health department across the United States is required to have a medical countermeasures plan. And that plan really is about our ability to support any kind of health threat in terms of mass dispensing or vaccinating. And Dr. Wood's kind of an expert on that as well, so if you have anything. So we're talking about a pandemic flu. We're also talking about potentially a terrorist attack that would involve chemical, radiological, nuclear, providing prophylaxis for that, which would be an antibiotic, et cetera, for that, or emerging diseases, excuse me. So one of the keys, or one of the, I'm going to skip order here, I'm going to go to, the purpose is that we have been tasked with being able to dispense to our entire population in Thurston County within 48 hours. This has been the planning module for about the last 8 years. We have often said with our shrinking public health workforce, even though we do have a medical reserve corps, that is just an incredible challenge to meet. And some of those federal directions are changing, and rather than it being 48 hours, they're looking for us to be able to potentially vaccinate on diseases or outbreaks such as pandemics that take a little bit longer to ramp up, that wouldn't need a 48-hour. So we're happy with that, but it is challenging. The operational piece of that is what we're doing is partnerships. And I think the last time I came here, you heard me talk a lot about meeting with people before the disaster. A couple of those partnerships, I think we came last year to you, we have a statewide pharmacy agreement. And where this fits in is some of our big box pharmacies have agreed to sign up, and they said, in the event of this need for mass dispensing, we'll step up. Bring some of the vaccine here, and we'll help support that. So partners for us are, I believe, some of the Fred Meyer. I don't have them all, but Costco's. There's Tim's Pharmacy in Yelm that has been a big partner. So all the way from small to big, that would help us do that. We're also going to look at getting out something to the general population if there's a threat. Doing it very quickly would be closed pods. So working with big employers like the state, et cetera, or even Thurston County, where if we told you had to go get a vaccine with 48 hours, you would go immediately to maybe your employer would host that. And then our last but not least piece, in which we do build up our medical reserve corps for, is the fact that we would do an open pod, an open point of dispensing. And I do have to say our MRC has been working on this for about the last 6 years. And we do 3 back-to-school clinics, which also fill another gap. And they do a great job of that. The Strategic National Stockpile is the national resource of life-saving pharmaceutical and medical supplies. I'm just going to let you know that there's caches all over the United States in the event that something needs to get out to a population quickly, so you know that. And those are pieces we have to plan. So a little bit about our emergency workforce. I always like to put that in. We rely very heavily on our MRC to support our medical countermeasures plan. That is really critical. They are incredibly skilled at it. I think Dr. Wood could even do a thumbs up that we could probably send them out to do a point of dispensing for vaccine on their own without any staff. Very dedicated folks.
Very good.
And again, those other components. There's another piece, though, that I want to share with you that we've been doing work on. And this is incredible. I think it's some of the best work that I've got to be involved in. We've been working with the American Indian Health Commission for Washington State. And we're close to bringing you a request to ask you to sign or give approval to sign a mutual aid agreement with our tribal nations. And this is specifically around support in helping them in public health threats.
Or are they helping us?
The greatest thing we found, Dr. Wood and I went down to Chehalis here a few weeks, the Chehalis Confederate tribe, and toured their wellness center. And we took away, I don't know about you, but I took away and they offered more help for us than in the reverse. So
I was very impressed.
Yeah.
So our next stop is Nisqually, but our tribal partnerships are important for us to remember because authority of the health officer to be able to go on that tribal land, they have to be invited. And as we all know, health threats don't stay within small boundaries or, defined boundaries as you and I roll them out. So working with our tribal partners, we have developed the mutual aid agreement. The next step is that we're taking a look at if it was a pandemic, say like H1N1, how would they get vaccine? How would that priority happen? And for Chehalis, we had that conversation down there. They said we'd offer vaccine for anybody that wanted to come to one of our sites. They wouldn't have to be a tribal member. So that reciprocal part coming back was a big takeaway from us. And that's a great point where we're at right now. Last but not least, our third project that we're working on is the Medical Reserve Corps, as you know. Really the medical, when it was developed and what we've evolved into, we have about 110 folks on there, is really to provide support for public health emergency functions. And we pushed very heavily on points of dispensing. A few of our folks were sent down, as I mentioned, to the Code Blue crisis. But we're looking at ways that we can pre-train, because one of the components of Medical Reserve Corps is they're pre-trained and they're pre-vetted. So they're not walking into a situation maybe that they don't know. Points of dispensing, we do first aid triage capability, psychological first aid, community education and outreach. Potentially, what is our future? We're going to look at what we call a wellness team for emergency shelter operations. Disease investigation teams would be something that we definitely want to look at. That gives you a little display of who our MRC volunteers are. Not that they wouldn't be willing to fill sandbags, but they're volunteering for a purpose behind the health and medical component that MRC stands for. So we really want to take that into consideration. Just some photos of the few things we've done in the last year. We're going to make sure that you all got an invitation to the May 2nd. We do a volunteer appreciation event. I'm going to close with that. And that's, Commissioner Blake, your comment. Our volunteers wanted more than just coming and having some desserts and coffee and getting an award. So Jennifer Dixon, who is not here because she has the cold that everybody has planned a component, and she's done a lot of work behind the scenes. They're going to put together wellness kits for those who may be experiencing homelessness in Thurston County. She's working with Meg as well as the City of Olympia. And so on that evening, when you all come, we're going to put you to work and you're going to put some kits together and the contents of those personal items, socks, etc. And so the MRC is really wanting to reach out a little bit more and do some other supported community events. And with the approval of our health officer as well as our director, we're going to definitely go in that direction. So with that said, I have all this neat, flowing in stuff on my PowerPoint. That's all I have to say today. Do you have any questions?
Yeah, we got questions and comments, sure.
On your strategic national stockpile, do you have a mechanism in place to check on those items, if you will, make sure they're there and secure?
All of that, the Strategic National Stockpile is run by the CDC, Centers
Center for Disease Control.
But I mean, I guess the reason I'm asking, I've been through this in the late 60s and 70s and even the 80s where we were decommissioning some of those locations and found out all the morphine was gone and those types of issues. And I just wonder, I don't know how much was damaged in the process, but I know it was an issue. So. Well,
I think the CDC has scaled back on what we stockpile now as identified as the biggest priorities. So it probably isn't as robust of list of medications and pharmaceuticals.
Well, there's a chain of command, as you may be well aware, for requesting the strategic national stockpile, and those caches are different parts of the country,
Right.
and they're supposed to get to us in a certain number of hours, depending on what we want. So there's very straightforward stuff that would get here in 12 hours, and other more complex medical supplies that would come later.
But it's really based on, they do set up an algorithm, so it isn't based on anything that could possibly happen. There's just isn't millions and millions of storage units around. So it's based on very specific targeted things that will need to go out. And so most of that in the past 10 years or so has been what I would say bioterrorism threats. And so most of what's stockpiled is for that. And of course, like vaccine, you can't store that because it's going to be developed, but the potential for that.
Okay.
Great, thank you so much.
Thank
Sue.
you.
It was
Thank
really-
you.
And I apologize. I normally have a question for you.
I know,
and
I
I'm
was
like,
wondering.
I'm
I knew you had
nothing
homework.
today.
No, very good.
We'll
Thank
take
you.
a rain check. So the next department item we have is a Thurston Thrives update, and I have here today Liz Davis from Thurston Thrives coordinator, and she is going to tell us about the Action Team Summit that's around the corner, huh?
Yes, thank you
There
for
you go.
having me here today.
You need a slideshow?
It's not really critical. Oh, yeah.
Mm-hmm.
So you'll be able to see in just a second all of the different teams that we have in Thurston Thrives. And I see it there. It doesn't like me for some reason. We'll just continue. You guys have the slides.
We'll get there. We'll get it.
Okay, so today was really interesting, even though I missed the first part of the meeting, because of all of the different teams that we have in Thurston Thrives. Almost all of them were addressed in some way during today's meeting. If you're looking at clinical and emergency care, you talked about housing, you talked about education and resilience, and just as I was looking through all of the things that we're going to be focusing on at the summit. All right.
There you go.
Hey, it worked. Yay.
Strong work.
Thank you. So one of the things that we've been trying to focus on for the last couple of years is not only having the action teams of Thurston Thrives working really hard on their individual activities, but also with doing some more cross-pollination. And Commissioner Blake sort of spearheaded doing what we called a nexus group that started with team members from housing, public safety and justice, and clinical, specifically behavioral health care, getting together and saying there are so many people within our systems that we're working with that are all the same populations. How can we serve these people better? And we've come to realize over the years that none of these teams are in isolation. When we're looking at health, I sort of see those as the Olympic rings or just a giant Venn diagram, and all of them touch other ones. And if we look at, what's the sweet spot that we can touch as many of those different topics to have the healthiest community, we want to be able to support that sort of communication. And so that's what this Action Team Summit is going to be about. It'll be at the Thurston County Fairgrounds Heritage Hall on March 22nd. Each of the action teams has been invited to send 3 participants, and then also our Climate and Clean Energy shared work group will send some participants as well. Also, About, I think, close to 10 members of the Thurston Thrives Coordinating Council have RSVP'd that they want to come. So
Fantastic.
that made me very excited that they want to come and take 4 hours of their day. I was an English major. Yeah, math, not really my strong suit. But that they want to take 4 hours and participate in this because they think it's something that is that worthwhile. We have a fantastic facilitator who is Linda Kleingartner from Taz Consulting. She also is the one that did our lean process in the county. So that's, the lead. It was a lean process, but it was the lead project. And she's fantastic. We really enjoyed working with her to put this day together. We did give some, so these are the objectives of the summit are to look back on sort of what has been accomplished in the last year, but then also to say, what do we really need to be prioritizing collectively for 2018? And we're going to be launching the Hope Thurston survey probably next month. And one of the things that we're going to be asking participants is if you could add another few questions to this survey, what would you want to know from our community? Because we're hoping to get many thousands of responses to that. And then to really focus on what are some of those possible areas for collaboration, those nexus points. In preparation for the summit, the teams were asked to reflect on some preparatory questions. So what do you think were your team's top 3 accomplishments of 2017? What are your very few brief priorities for 2018? Not a laundry list, but especially since we're looking to find areas for collaboration, if we can narrow down that list a little bit, it will help. And what are some of the gaps or unmet needs that you're seeing in your action area? And what are those potential collaborative points that you see that are possible and that align with priorities for 2018? So, as always, people can check out our Thurston Thrives website at thurstonthrives.org. We also are on Twitter at twitter.com/ThurstonThrives, facebook.com/ThurstonThrives, and contact information for Chris Hawkins and me is up there as well. Any questions?
Comments, questions?
Thank you very much.
Thank you for having me.
Thurston Thrives is primarily for social determinants, and that's kind of what the teens are rallying around in another kind of way. I just want to touch on that, because I know that's kind of the bottom line up front, what Thurston Thrives is about, right?
Right. I buried the lead. Thanks for giving me the opportunity to explain. Yeah. Yes. So if you look at those different pieces of what all the action teams are, is a full picture of community health. That we need all of these things to be in good working order for all of the people of our community to be healthy. Yeah. So it's not just having good clinical care, it's also being prepared for emergencies. It's also having clean water and healthy food to eat and enough food to eat. And good schools.
And ACEs, right?
No ACEs.
No ACEs?
Prevention of
okay, there you go. I'll take that.
So, yes, prevention of abuse and neglect and family dysfunction. That all of these things are necessary for a healthy community.
There you go. All right.
Thanks so much.
Okay, now we move on to the part of the agenda where we have the pass on the director's report and go to the health officer's report. Is that all right?
Well, actually, Shelley did email me, so I'm going to read it.
Oh, my God. Okay, here we go. Shelley threw a box, huh?
Yes. Good afternoon. On behalf of our department director, Shelley Slaughter, I have some very exciting news to share. First of all, Thurston County now ranks the 6th healthiest among Washington state counties on the nationwide county health rankings released today. And in 2012, Thurston County ranked 14th. So
Wow.
we're moving up.
That's fantastic.
And the county health rankings grade counties across the state as well as at the national level. There's over 3,000 counties in the U.S. And it looks at how healthy the community will be in the future. The rankings are produced each year by the University of Wisconsin Population Health Institute and the Robert Wood Johnson Foundation. And Thurston County scores better than the state of Washington on several measures covered by the county health rankings, including fewer people are dying young, fewer people without health care, lower rates of violent crime, and fewer preventable hospital stays. And this is in a large part due to our community's collaborative efforts to focus on the social determinants of health through Thurston Thrives. And the county health rankings show that focusing on health behaviors and social economic factors is making a positive difference. I'm going to move on to tobacco and vaping prevention. But let me just say the public can view the rankings in detail by visiting www.countyhealthrankings.org. So if you go to that, you can get more information. There's tobacco and vaping prevention. Regional implementation is underway. Several counties are moving forward together on a social media campaign to increase awareness of impacts of use of young people throughout their lifespan, along with distribution of smoking, vaping, in public places signs, and working on policy development. The Cascade Pacific Action Alliance, some of our partners in the 6 other counties, we're a 7-county coalition. Our alliance was notified it received 100% in the review of Medicaid Transformation Project portfolio by the state's health care authority. Public Health and Social Services contributed to the development of that portfolio, and it was rated as one of the top 2 highest in the state. Awesome. The successful effort will bring millions in Medicaid funds for sets of projects that includes opioid response and chronic disease prevention. On another note, our maternal and child health team completed a 1-year training in infant mental health that was funded by a scholarship through the Department of Early Learning. We have been awarded an additional scholarship that will cover the cost of each nurse's endorsement through the Washington Association of Infant Mental Health. The process of becoming endorsed is lengthy, but signifies the high level of training, knowledge, and skills that our maternal and child health team brings to their work. And in 2017, our Thurston Nurse Family Partnership Program serves 225 families and will serve even more with the expansion into Lewis and Mason counties. And I'm very excited about that as the health officer in both Lewis and Thurston. Thurston County's 2018 Consolidated Request for Proposals is now open as of February 28th. The 2018 Consolidated RFP encompasses funding for the following 4 programs: Community Investment Partnership, Homeless and Affordable Housing, including federal HOME or Home Program funds, as well as SHB 2060 and ESHB 2163 funds. Also, the Community Development Block Grant for City of Tumwater projects Veterans Emergency Shelter Bed Program. And the link to the RFP will be posted to the county's website, and proposals will be due April 6th. That's a Friday, 2018, April 6th by 12 p.m. or noon. In other news, and then I will move, with your permission, smoothly onto the health officer report.
Absolutely, sure.
Okay, but just to finish up Shelley's report, the director's report, we issued this month 297 birth certificates and 797 death certificates.
Oh, my word.
So I would like to let you know that influenza remains, it went down and then it went up again this week. And we're seeing some fairly ill people with increased number of positive influenza tests, the percent positive of the number run. This is true both for St. Pete's Hospital and for Capital Medical Center. We've had one area of our county has had 5 pertussis cases, whooping cough. 1 suspect and 4 confirmed in elementary and middle school age children. So getting your vaccine against pertussis is still recommended. We also are managing and doing directly observed therapy for 3 active tuberculosis cases. And with that, I will stop unless you have any questions.
No, I don't. I don't have questions.
No, a great rundown from both
Great.
Shelley in the box and Dr. Wood.
Okay.
So, okay. Any final comments that you have or anything
A lot
you want
going on.
It never ends, does it?
Never ends.
Okay.
We're a hopping place.
I know Thurston County
And-
rocks.
And we really don't realize how good we have it individually.
Is there a motion to adjourn?
I would so move
The
that
second.
we will adjourn for our March 13th, 28th.
There you go. We are adjourned.